Heart failure. By Dr. Zor. Heart failure. What is heart failure? It is a condition when heart is not able to pump the blood to support physiological circulation. Cause may be structural or functional. Heart failure main cause is ischemic heart disease, 35 to 40%. Cardiomyopathy, dilated, 30 to 34%. Hypertension 15 to 20%. Other causes: valvular heart disease, congenital heart disease. Prognosis: 50% of patients with heart failure are dead in 5 years. Causes of heart failure. Heart failure pathophysiology. When heart fails, changes occur in heart and peripheral vascular system. They are: ventricular dilatation, increased ANP secretion, salt and water retention, sympathetic stimulation, peripheral vasoconstriction. These changes are compensatory and maintain COP and peripheral perfusion. Heart failure pathophysiology, CONT. When there is heart failure, amount of blood ejected per beat decreases, there is more end diastolic volume. Heart rate increases, therefore, any reduction of stroke volume is compensated by increased heart rate to maintain COP. COP equals stroke volume times heart rate. Heart failure pathophysiology, CONT. When there is severe cardiac dysfunction, increased venous pressure on left side of the heart leads to back pressure in lungs and causes dyspnea, due to accumulation of alveolar fluid. There is hepatic enlargement, ascites-independent edema, due to right ventricle failure. In severe heart failure, COP is reduced at rest. Heart failure pathophysiology, CONT, outflow resistance, after load. Normally ventricle contract against load or resistance, which is formed by 1. Pulmonary and systemic resistance. 2. Blood vessel wall. 3. Volume of blood that is injected. Increase in afterload, decreases cardiac output, it will increase in diastolic volume and causes dilatation of ventricle. Heart failure pathophysiology, CONT. Decreased cardiac output leads to diminished renal perfusion, activating renin, angiotensin, aldosterone system and increases salt and water retention. Heart failure pathophysiology, CONT. Myocardial remodeling in heart failure. There is alteration in ventricular size, shape, and function in clinical conditions, for example hypertension, cardiomyopathy, valvular heart disease and ME. Heart failure pathophysiology, CONT, natriuretic peptides, ANP, BNP. ANP-atrial natriuretic peptide is released from atrial myocyte in response to stretch. ANP is increased in CCF, causes diuresis, natriuresis, vasodilatation, and suppression of renin, angiotensin system. BNP, brain natriuretic peptide. It is called BNP because it was first discovered in brain, but it is predominantly secreted by ventricles and has similar action of ANP. Heart failure. Heart failure clinical syndrome of heart failure. Heart failure can present as acute heart failure, chronic heart failure. We will discuss each one. Chronic heart failure. Left ventricular systolic dysfunction, LVSD. It is commonly caused by ischemic heart disease but also occurs with valvular heart disease and hypertension. Right ventricular systolic dysfunction, RVSD. It may be secondary to LVSD, pulmonary hypertension, right ventricular infarction, heart failure. Chronic heart failure. Diastolic heart failure. It is a syndrome where left ventricle relaxation is abnormal. There is stiffness in ventricular wall and decreased LV compliance, leading to decreased diastolic ventricular filling with reduced cardiac output. Ejection fraction of left ventricle is about 45–50%, normal 60%. Cause hypertension in elderly. hypertrophic cardiomyopathy, restrictive heart failure, chronic heart failure. Symptoms and signs of chronic heart failure. Symptoms: exertional dyspnea, orthopnea, proximal nocturnal dyspnea, fatigue, heart failure, chronic heart failure. Symptoms and signs of chronic heart failure. Signs: hypotension, the basal crackles, cardiomegaly, pleural effusion, third and fourth heart sound, angioedema, elevated JVP, ascites, tachycardia, tender hepatomegaly, heart failure. Classification of heart failure. Heart failure, chronic heart failure, diagnosis of heart failure. Symptoms and signs of heart failure, e.g. breathlessness, JVP, angioedema, liver enlargement. X-ray just, look for cardiomegaly, pulmonary congestion and pulmonary edema. ACG- ischemia, hypertensive changes, arrhythmia. Echocardiography, cardiac chambers, systolic and diastolic functions, valvular heart disease, cardiomyopathy, heart failure, chronic heart failure, diagnosis of heart failure. Other investigations. Blood test, FBC, liver biochemistry, U&E, cardiac enzymes. Nuclear cardiography, radionucleotide angiography, RNA, for ventricular ejection fraction. SPECT, single photon emission computed tomography, can demonstrate myocardial ischemia and dysfunction of myocardium. CMR, cardiac MRI, for myocardial dysfunction. Heart failure, cardiac catheterization, cardiac biopsy. Chronic heart failure, CHF. Investigations. Cardiac catheterization. For IHD, revascularization. Pressures in heart chambers. Cardiac biopsy. Cardiomyopathies, for example amyloid. Follow-up in transplanted patients to assess rejections. Ambulatory 24-hour ECG monitoring, Holter, in patients with history of arrhythmias. Heart failure prevention, general lifestyle, chronic heart failure. Treatment of heart failure. Prevention. Avoid smoking. Avoid alcohol. Treat hypertension. Treat diabetes mellitus. Treat hypercholesterolemia. General lifestyle. Control of obesity. Dietary modifications, avoid large meal. Restrict salt intake. Low-level exercise, walking 20 to 30 minutes 5 times per week when tolerated. Heart failure, general lifestyle, chronic heart failure. Treatment of heart failure. General lifestyle, driving. Person can drive. Symptomatic heart failure if present, person should not drive large lorries and buses. Multidisciplinary team approach, many healthcare personnel are required. Nurse, specialist in heart failure. Dietitian. Pharmacist. Occupational therapist. Physiotherapist. Heart failure drug treatment, chronic heart failure. Treatment of chronic heart failure. Drug treatment. Diuretics, causes renal excretion of salt in water. Loop diuretics, for example furosemide, Lasix. Thiazide diuretics, for example hydrochlorothiazide. ACE inhibitors, for example captopril, enalapril. They are useful, they slow down the development of heart failure and improve survival. Side effect: cough, hypotension, hyperkalemia, renal dysfunction. Contraindications: renal artery stenosis, pregnancy. Heart failure, chronic heart failure, treatment of chronic heart failure. Drug treatment, angiotensin II receptor antagonist, ARA, for example valsartan. They are second-line therapy, used if patient is not tolerant to ACE inhibitors. They do not affect bradykinin metabolism, therefore do not cause cough. Beta blockers, for example Tinerman, Concor. They reduce cardiovascular morbidity and mortality. They decrease oxygen demand. In heart failure, start with low dose and gradually increase dose. Heart failure, chronic heart failure, treatment of chronic heart failure. Drug treatment, CONT. Aldosterone antagonist, for example spironolactone. Improves survival in heart failure. Cardiac glycoside, for example digoxin. Indicated in AF with heart failure. Vasodilators and nitrates, hydrolysine and nitrates reduce afterload and preload. They are used in patients who cannot tolerate ACE and ARA. Prophylactic anticoagulant is an HF as there is fourfold increased risk of stroke, heart failure, chronic heart failure, CHF. Treatment of chronic heart failure. Non-pharmacological treatment. Biventricular pacemaker and implantable cardioverter defibrillator. Indicated in patients with synode and avenue node conduction blocks. Heart failure CHF, non-pharmacological treatment, CONT. Cardiac transplantation. Indicated in younger patient with severe heart failure, whose life expectancy is less than 6 months. After heart transplant, expected 1-year survival over 90% and 5-year survival 75%. Quality of life is improved. Acute heart failure, AHF. Acute heart failure, AHF. AHF occurs with rapid onset of symptoms and signs of heart failure. This causes severe dyspnea, pulmonary edema and peripheral edema. AHF has poor prognosis with 60 days mortality of 10%. Poor prognostic indicators. Pulmonary capillary wedge pressure, PCWP, more than 16 mm of mercury. Decreased serum Na+. Increased left ventricle and diastolic dimension on echo. Decreased O2 consumption. Acute heart failure, AHF. Etiology of AHF. Ischemic heart disease, acute coronary syndrome can cause papillary muscle rupture or VSD, ventricular septal defect. People with valvular heart disease can present with AHF due to endocarditis or prosthetic valve thrombosis. People with hypertension can present with pulmonary edema. Acute and chronic kidney disease can cause fluid overload and pulmonary edema. Atrial fibrillation, AF, is associated with AHF and may require cardioversion. Acute heart failure, AHF. Clinical syndromes of AHF. Acute heart failure, AHF. Diagnosis. 12-lead ECG- for acute coronary syndrome, left ventricular hypertrophy AF. X-ray just, for cardiomegaly, pulmonary edema. Blood investigations, cardiac enzymes. Blood BNP, more than 100 pg/m indicates heart failure. Echocardiography, to confirm heart failure. Acute heart failure, AHF. Treatment of AHF. Goals of treatment in AHF. To relieve symptoms. Reduction in stay in hospitals. Reduction in mortality from AHF. Monitor heart rate, BP, temperature and cardiac monitoring. All patients require low molecular weight heparin as prophylactic coagulation, for example enoxaparin 1 mg/kgs.c ×2 daily. Atrial blood gases. Central venous cannulation for 1/V medication. Acute heart failure, AHF. Treatment of AHF, CONT. Initial therapy. O2. Diuretic, for example Lasix. Vasodilator, GTN infusion. Inotropic support, for example dobutamine. If blood pressure is low, use norepinephrine.